Hello everyone. So let's talk about the unconjugated hyperbilirubinemia causes in a newborn. Okay. So first of all, if there is increased load on the liver for conjugation of the bilirubin, as in case of hemolytic anemias, when there is ABO or RH incompatibility, there is hemolysis, breakdown of red blood cells. Okay, and the heme goes and gets converted into bilirubin. So the increased bilirubin needs to get conjugated in the liver, and newborn liver, as we all know, is immature and it does not have the capacity to conjugate larger amounts of bilirubin. So hemolytic anemias is the first important cause. Second is neonatal polycythemia, where there is increased RBC mass, therefore increased breakdown of the red blood cells. Third is bruising, like cutaneous bleeds in the case of traumatic deliveries, okay, cephal hematoma. So that blood that has collected there, that breaks down over a period of days and causes increased bilirubin that needs to be conjugated in the liver. Internal bleeding, like in case of IVH. Short RBC span in cases of neonatal sepsis, acidosis. Okay, RBC enzyme defects like G6PD deficiency, pyruvate kinase deficiency, blood transfusions. So transfused blood has a shorter RBC lifespan. So all these are again causes of elevated bilirubin in a newborn, the unconjugated form. And also increased enterohepatic circulation when there is reduced feeding, okay, as in case of breastfeeding jaundice, and when there is delay in passing meconium, the conjugated bilirubin that has entered the gut through the CBD, that again gets converted to unconjugated form in the gut itself, and that is absorbed and sent back to the liver. So that is circulating in the blood again and causing elevated unconjugated bilirubin. The second important cause is reduced activity of the enzyme required for conjugation. So we all know that UDP glucuronide transferase is the enzyme required for conjugation of the bilirubin. So when there is reduced activity, as in case of hypoxia, okay, in case of perinatal asphyxia basically, then thyroid dysfunction, hypothyroidism in the newborn, congenital hypothyroidism, infection as in case of newborn sepsis, and genetic deficiency of the enzyme. Okay, so genetic defect in the enzyme, okay, presents with the two forms, okay, genetic forms of familial non-hemolytic hyperbilirubinemia in the newborn. So one is Crigler-Najjar syndrome and second is the Gilbert syndrome. In both of these there is a genetic defect. There is a mutation of the UGT1A1 gene. UGT1A1 gene. So remember this is an important question for your MCQs. The third important cause is competitive inhibition of this enzyme by drugs. So a newborn given chloramphenicol, novobiacin, lactams and sulfa group of drugs. These are the drugs that will cause competitive inhibition of this enzyme and therefore delay the conjugation of bilirubin. Fourth important cause is reduced bilirubin uptake by the liver for conjugation, like in the case of reduced blood flow to the liver, in cases of CCF, portosystemic shunt, rifampicin administration to the newborn, rifampin administration, that can again cause reduction of bilirubin uptake. Oxytocin use in the mother for induction of labor, again that is known to cause unconjugated hyperbilirubinemia.